Professor and Head, the Department of Pathology, AIIMS, New Delhi. He will be assisted by Dr. Balamurgan, Assistant Professor at about the upcoming talk.
Let me start by sharing the screen. Are you able to see my screen now?
Yes, sir.
Yes.
Okay, so may I request the first resident to start their speaker. I think it was the last resident. Her name was, I missed the name. I am not going to deliver a talk on cell death or apoptosis or necrosis. Instead, I will just interact with you because these are increasingly being said on this side, which is just to say that I'm a cytologist and the father of cytology, Robert Hooke, was much older than the father of pathology, who was Rudolf Virchow. And do you remember this from your school? Omnis cellula e cellula, and what it means? Would you like to say what it means?
There is a precursor cell.
So all cells come from pre-existing cells. So you cannot, so this was something which was told 100 years ago. But when we are discussing cell death and cell injury, I would like you to remember that all mitochondria also have to come from pre-existing mitochondria. So if I say that all the mitochondria of a cell are dead, will that cell be able to survive or not?
No.
No, because all mitochondria, so it cannot make more mitochondria. It can make more other organelles. It can make more endoplasmic reticulum. It can make more lysosomes, more everything, but not more mitochondria. So the last mitochondrion from a cell is gone. That cell is irreversibly damaged. Right?
Yes.
So if you look at the contribution of this gentleman, that is Rudolf Virchow, he is the one who started our entire concept of cell injury. So here we have a normal cell. So the hypoxic model is when you deny oxygen to tissue, it gets damaged. So no ATP, no mitochondria, right?
Yes.
Here we have a cell culture normal cell. Here we have a cell which is injured. What has happened to this cell?
Cytoplasmic collapse.
Okay, so this is actually cell swelling. In cell culture, cells don't swell like it does in tissue. In tissue, it looks ballooned. So it looks like this. Now here we have a normal cell, this is a normal rough endoplasmic reticulum. What has happened to the endoplasmic reticulum in this cell over here, which is injured?
Swelling.
Swelling. Why has it swollen up? Because if you deny oxygen, no ATP. And if no ATP, what happens to the cell?
The sodium potassium channel is affected.
Exactly.
So there is influx of fluid into the cell.
So normally you throw 3 sodium out for 2 potassium in. And if you don't keep throwing the sodium out, the cell becomes swollen. There is more sodium and therefore the water follows along with it. And the first place where it accumulates is this endoplasmic reticulum. It becomes swollen. Now here we have ribosomes collected together to form polysomes. What has happened to the polysomes over here in this injured area, injured cell?
So
here they are coming in groups, right? So here it is not coming in groups. So this is called disaggregation. So normally polysomes are aggregated. Each of these represent a mRNA which is being translated by this group of ribosomes. More than one ribosome is going to sit on a cell. Here it has become injured, and therefore ATP is required for protein synthesis. Ribosomes disaggregate. If it's a rough endoplasmic reticulum, it will leave. Now, what do you know about free radicals? Anything you can tell about free radicals?
They have an unpaired electron, so they are very highly reactive. So when they react with the other molecules, they are also changed into a free radical.
Absolutely. So you're absolutely right. They transfer a free electron. In the process, they cause a molecular transformation. They break a bond or they cause a bond to form. And at the end of that, the free electron is still left unpaired to cause more damage. Right? It's like passing the parcel. It is going from this to this to this until finally it is quenched in some way. So, which all substances are damaged by free radicals? Do you know that?
The phospholipids,
What happens to the phospholipids?
the bond is broken. The fatty acids combine.
So in cell membranes, you have which type of PUFA or what kind of fatty acids?
Yeah, unsaturated.
Unsaturated. So polyunsaturated. So each unsaturated is a double bond. So what this free radical will do to the double bond?
They make it. They break the double bond and form.
Once two double bonds are broken, those two PUFAs can join together to form a polymer of those fatty acids.
Single fatty acids.
And then what is the end result of this type of damage?
They affect the membrane, cell membrane.
So the cell membrane can actually bind itself up into this kind of myelin figures. So myelin figures are a feature of free radical injury. Myelin figures are also a feature of two other processes. Would you know what they are?
Also, it's seen in necrosis. Also, it can be seen.
Okay, so in necrosis, it is because of free radical injury. But apart from that, it can also be seen in apoptosis. And it can also be seen in certain storage diseases. Can you give an example?
Storage disease.
You can get it in Niemann-Pick disease.
Niemann-Pick.
So another form of cell death in which you get myelin figures is autophagic cell death. So if an organelle is being broken down, that organelle will also convert into a myelin figure at the end. What is a histomorphologic counterpart of lots of myelin figures or apoptotic debris or autophagy or breakdown of this nature?
They're more amorphous eosinophilic. And they can combine with calcium.
So it can also form what we call as lipofuscin pigment, wear and tear pigment. Wherever you have a lot of damaged cell membrane organelles, these membranes become unreactive, and that's why they don't take up any stain, but they can get a light brown pigment and become lipofuscin. These are some. Let us quickly go over what an apoptotic cell looks like. What has happened to the cell here? Why do you think the nucleus has become like this?
Right.
So when a cell undergoes apoptosis, what happens to it? Okay,
They
let us
break
go
into
over what all can
fragments.
happen in that, and then we'll come back to the previous slide. So these are the end result of activating all these caspases which are there. So if you activate caspase 3, what all can happen because of that? Cytoskeleton will
Break.
aggregate. So these could be cytoskeletal aggregates. Then actin will depolymerize. So if actin depolymerizes, what will happen?
Bleb formation.
Excellent. So you have these cytoplasmic webs on EM. Then you have, well, it can inactivate the cell cycle because it will stop dividing. Then there is this very important thing. There is caspase activated DNAs. What does this do?
They fragment the nuclear DNA
Yeah. And what they call it internucleosomal. What does that mean?
between.
So it cleaves it between the nucleosomes. So nucleosomes are 180 base pairs wound on the histone protein, which have now recently become very important in cancer biology. But they cut it in between those. And so if you run this DNA on a ladder, on a gel, you will get a ladder pattern of smearing rather than a smear pattern where all types of breakdown are going on. So this is because of enzymatic cleavage. Then it can also activate certain enzymes like phospholipid flippase and scramblase, which cause expression of
Flipping.
certain things which can be detected on the cell surface. What are those things?
Phosphatidylserine, the flipping of phosphatidylserine,
And
and which is
annexin V or 5.
next in is
If you want to mark an apoptotic cell, what are the techniques available?
you can stain. I mean, annexin is used.
So you can use annexin because there is an antibody against it. What else you can use? You can use this caspase 3. So here we have a heart muscle. This particular cell is stained with caspase 3. So it's an apoptotic cell. What else you can do? What is this tunnel? So tunnel is TDT and NEL is nick end labeling. So wherever you have nicks, so this internucleosomal cleavage creates nicks, and you can use an enzyme called TDT, which is what you use to stain. Which tumor is positive for TDT?
TDT T cell.
For lymphoblastic lymphoma, yeah.
T
So
cell.
lymphoblastic lymphoma will be positive for TDT, but that same enzyme can be used for other functions. In the lab, it can be used to do a nick end labeling. So if there is a nick inside the nucleus, you can stain it. So this is just a brief overview of morphologic. So here we have done not we, somebody has done staining for annexin V over here, right? So let me not go into such details. We will come to it at the end. I will just say that I'm very thankful to Dr. Bala Murugan, who has taken out cases in which the cells that we have just discussed, those type of injured cells are present. What these are, we will allow Dr. Bala Murugan to present. So I will request the moderator to please take over.
So, Dr. Balamurugan will be sharing his screen right now.
Yeah, is it visible?
Yes.
Yeah. So thank you, sir. Like to thank Dr. Gujral and his team for providing this opportunity, and Dr. Venkat sir. So we can start with the cases. So who will be presenting the first case?
Me, sir. Tolis Mehta, sir.
Okay, so you have seen the slides
Yes, sir.
and slides. Okay. So can you tell us the history of this case?
A young child presented with cervical lymph node enlargement since 2 weeks. There was no loss of weight or appetite, and cervical lymph node excision was done.
Okay. So based on the history, can you assess anything that what is this child may have? What are the possibilities which you know if there is an enlargement in the lymph node enlargement in a kid?
Maybe due to infection, sir,
Okay.
or due to malignancy.
Okay. So you have given us two possibilities. One is infection, or second one is malignancy. Okay. So it is a 2-week duration, and there is specifically we have mentioned there is no weight loss or appetite. So generally, where do we use loss of weight and appetite? For which condition do we use?
Loss of weight is generally associated with malignancies or tuberculosis also it might be.
Yeah, okay, fine. So let's dwell into the slide. Can you see the scan slides?
Yes, sir.
Okay. So can you please describe?
Section shows effaced lymph node architecture, displaying displaying multiple granulomas along with small mature lymphocytes.
Okay.
The granulomas are comprising of epithelioid histiocytes and multiple giant cells.
Mhm.
There are large areas of necrosis
Okay.
surrounded by inflammatory cells. These necrotic areas are consistent with eosinophilic amorphous necrotic debris,
Mhm.
which is suggestive of caseous necrosis.
Okay.
There is no evidence of any malignancy or a malignant cell.
Okay. Good description. So, would you like to say to others did you say that there is effacement of architecture? Why is it important?
Effacement of architecture will be seen in granulomas or in any kind of malignancies also.
Yeah. So that means there is loss of normal lymph nodal architecture. Okay.
Normal
When there is loss
architecture
of
will be
architecture.
lost.
When you're talking about, let me just butt in. Normally, when you use the word effacement of architecture and the lymph node has a focal lesion, that focal lesion area you are supposed to ignore. So in this slide, for example, there is some small corner somewhere where some normal lymph nodal architecture which is not involved in a focal lesion. A focal lesion can be an infection or a malignant deposit, a metastasis. The remainder of that, you have to assess whether the architecture is normal or not. And if that architecture is normal, you don't utter the word effacement. You say that the lymph node is mostly replaced by areas of granulomatous inflammation with necrosis, or you might say replaced by a tumor deposit.
Yes.
Yes, Bala, please continue.
Sir. Yeah. So as sir was telling, we are finding some preserved architecture here in the peripheral lymph nodes, and as you were describing clearly that there was presence of this multiple necrotic focus. So does this focus resemble something else? What we call this is these are called as geographic necrosis. Okay, it is involving a large amount of area, and central areas you are finding there is this eosinophilic granular necrosis. Okay, so these are the palisading histiocytes, and can you see the multinucleated giant cell here?
Yes.
Okay. So what are all your differential? Did you find any focus of active inflammation like neutrophils? Anything else?
Mostly it's a mononuclear inflammation by lymphocytes and plasma cells.
Okay. So sometimes if you one thing odd about this case is the size of the granulomas. Okay, these are all massive granulomas with there is geographic necrosis here. Somewhat it resembles a scar-like lesion, star-shaped necrosis, and we are having some multiple debris with this palisading histiocytes and this multinucleated giant cells. So as you rightly said, this is a granulomatous inflammation. Okay, if you proceed with our presentation, so the discussion will be based on the approach to a diagnosis, the differential diagnosis, and the special stain. Okay, so we are finding there is geographic or stellate necrosis with palisading histiocytes and granulomas. So what would you do next?
We'll go for an A/B stain, sir. Acid fast stain for acid fast, ZN stain, Zil-Nielsen staining.
Okay, so apart from that, we'll do only AFB or anything else?
PAS and CSM also. PAS and CSM, sir, for fungal infection.
Yeah, so we'll do a PAS diastase and a silver methenamine stain. Okay, so we have to rule out tuberculosis as well as fungal infections. Okay, so something odd about this case is that there were presence of this large geographic necrosis with stellate shaped necrotic areas. There are occasional neutrophils, very minor amount of neutrophils here. So so this picture which initially saw in the scan slides, we have center necrosis with palisading histiocytes, and there were this presence of these granulomas. So can you tell us some differentials for granulomatous inflammation?
So tuberculosis, atypical mycobacteria, and then fungal infection like histoplasmosis, cryptococcosis, or syphilis, cat scratch disease.
Okay, so you told everything. So we broadly classify granulomatous lymphadenitis based on the whether there is suppurative lesions or not. Okay, what a suppuration means? The presence of polymorphs. Okay, so if you see in this picture here, we have a central collection of neutrophils with palisading histiocytes and granulomas. So if there are suppurative granulomas, what are the differences one need to consider are the cat scratch disease, tularemia, brucellosis, Yersinia. And in case of non-suppurative granulomas, predominantly what we have discussed, that is mycobacterial infections. In fungus, we have Cryptococcus, histoplasmosis, and other fungal infections, non-tubercular mycobacterium, and syphilis. So some causes of other causes of granulomas inside the lymph node can be because of sarcoidosis, foreign body granulomas, and Crohn's disease. So we basically differentiate based on the separation or not. What happens is, as the age proceeds, or what happens if the lesions are in long term, there is resolution of the suppurative lesion. Patient might take NSAIDs, and as per the time increases, the element of separation decreases, and we will find only necrosis in that. So, as you said, we also have done some special stains like Zeal-Nielsen and past diastase. So, Zeal-Nielsen stain was negative, and past diastase did not highlight any fungal profile. Do you know why we did Warthin-Starry in this case?
Silver stain, sir, for cat
It's a silver stain for cat scratch disease.
scratch
Okay.
disease.
We repeated twice and it was also negative. So based on the geographic necrosis and the large granulomas, we have given two possibilities. One is tuberculosis and cat scratch disease for further workup. So the discussion of this case will be based upon the cat scratch disease. We all know that it is caused by Bartonella henselae and it is acquired by the arthropod vector, that is from cat flea, or it can be by the direct inoculation by cat scratch. Whenever a cat scratches, the entry of this bacteria is through that channel, and locally there will be formation of red papules and pustules. This is the skin lesion, and then there will be development of regional lymphadenopathy in 1 or 2 weeks. So mostly the sites include cervical lymph nodes and axillary lymph nodes. And in up to 1/4 of the patients, they do not recall any history of cat scratches. So this can also occur without any history of cat scratches. So what happens in the later stages, there is resolution of the separation, and we can see only erase of necrosis. The important thing is that one should know that you have to do a silver stain also, that is Warthin-Starry stain, or even immunohistochemistry to highlight the bacilli. So this patient is being worked up for tuberculosis and cat scratch disease. So what are the other investigations you can ask the clinician to do? One is the serology for Henselae antibodies, that is IgG antibodies. Okay, so we can also do PCR for the mycobacterium as well as this bacilli. So how do we give sample for this? Do you know? You have a paraffin tissue with you. Can you do PCR from that? If the clinician forgot to take sample while doing FNAC or any excision biopsy, can you ask? Can we do any other investigation? So using the paraffin blocks which you have, we can cut scrolls out of that, and that can be sent for molecular workup. Okay. So this Bartonella henselae, as you can see, this image is taken from the internet. Here you can see that these are these Warthin-Starry positive bacilli. It is very difficult to identify them. We need to pay more attention and find out this organism. We know that this is a self-limiting acute lymphadenitis. There is a resolution in 1 or 2 months, and it can rarely cause conjunctivitis, purpura, and sinus diseases. So this is the primary lesion and the development of this regional lymph node for this patient. So, sir, any questions, or ma'am, can you?
So, can you tell us causes of geographic or stellate necrosis with granulomas? Apart from cat scratch disease and tuberculosis, what you had a long list, but can you choose some where this is common?
Cat scratch disease is the first one, sir. And
no, not you. I'm asking the residents. So you can also get it in lymphogranuloma venereum.
Yeah.
You can get this type of necrosis in solid masses of adult filarial worm. So sometimes you get subcutaneous nodules. There also, if you cut a section, you'll get stellate necrosis like appearance. And if you don't hunt for it, you will miss the filaria. You can get it in lymphogranuloma venereum, which is inguinal disease. Which fungus commonly causes this type of lesion? Generally not crypto. Which one?
Histoplasma.
Yes, so histoplasma can give this type of appearance. Any other fungus, sometimes it gives this kind of appearance. You can also get it in some cases of mucormycosis, where there is, especially mucormycosis similar to Basidio bolus, entomophtera mycosis, certain kinds of cutaneous infections. You get granulomas and necrosis, which looks like this, and you might miss the fungus. So, may I request ma'am to say anything more on this or any more differentiation?
Thank you, sir, for so nicely explaining this very basics, especially the necrotizing lymphadenitis. So basically, one should remember the site specificity also. Like if you have the same morphology in cervical region, it is think of cat scratch. The same morphology in the inguinal nodes, think of LGV. That is one. Secondly, there are many other diseases and many other pathologies in which you will see a necrosis which is predominant. So it's along with necrosis, like sir has very nicely explained. Along with necrosis, it's the other types of cells which are surrounding and the cells which are associated with that. Suppose you're seeing giant cells, you're seeing Langer's type of giant cells, you're seeing a necrosis which is a caseous form of necrosis with no polys, then you'll think of TB. If you're seeing just naked granulomas without any lymphocytic rim, think of sarcoid. If you're seeing necrosis with polys, think of cat scratch disease. And if the histiocytes are palisading but no neutrophils, then you think of fungal. So in your mind, when you're seeing the slide, you make a differential diagnosis based on the associated features. And sir, thank you, sir, for so nicely explaining, Dr. Bala and Iyer, sir. Thank you, sir.
Okay, ma'am. Can we go to the next?
Go to the next slide.
Who's the next person?
Sir, it's me, Dr. Naganandani, sir.
Hi, Naganandini. So
Good
can you read
evening,
out the
sir.
history?
Yes, sir. A 24-year-old female patient presented with painless enlargement of axillary lymph node. She had fever, weakness, and weight loss. Core biopsy of lymph node was done. HNE, CD3, and CD20 slides are provided.
Okay. So can you please describe us?
Yes, sir. So sections show 6 linear cores of breast lymph node showing lymphocytes with areas of necrosis along with eosinophilic karyorectic debris, and one foci shows histiocytes. Few areas show crescentic histiocytes. There is no intact neutrophil seen in the sections examined, and the following slides of IHC CD3 and CD20. CD3 diffusely strong and positive, and CD20 it shows positive only on the germinal centers like follicular center cells.
Okay. So very well presented. In addition, do you want to add anything about? Did you find any large atypical cells?
Yes, sir. Mature lymphocytes along with
No. Did you find anything like suspicious for lymphomatous process or anything? Hello.
yes, sir.
Yeah. Did you find any atypical cells? Any lymphoid cells? Reed-Sternberg cells? Anything?
Yes, sir. Reed-Sternberg cells in few foci. Reed-Sternberg cells. It's like Reed-Sternberg cells.
Okay, but you're not very sure about that. Okay. Any well-formed granulomas, any fungal infection shadows, negative shadows, anything like that?
No, sir. I could not see
Okay.
any.
So can you summarize your findings and can you arrive at a differential or a diagnosis?
Yeah. From the findings, my differential diagnosis are it's necrotizing lymphadenitis.
Okay.
But probably Kikuchi's Fujimoto's disease.
Okay.
Or
Good.
differential
So,
diagnosis or
yeah. Yeah, please tell.
differential diagnosis or infectious lymphadenitis and autoimmune diseases like SLE, And
Mhm.
malignancy like lymphomas, mainly
Malignancy
Hodgkin's and
like lymphomas. Acha,
non-Hodgkin's.
you want to say any lymphomas?
Hodgkin's and non-Hodgkin's lymphomas.
Okay. So you presented very well till the end, but when you're gonna give a differential, we have to be very, during examination section when things are very obvious, like you see the 90% of the case you have solved, don't go for the minor one, like 10% you just want to add for your safety. So don't do that. You have very well presented, you have beautifully described the findings. So I just wanted to uh, quickly reiterate the findings to the participants. You are finding that there are 3 cores of lymphoid tissue. So this is a
Yes.
core biopsy. As you can
Yes.
see, there are still some preserved lymphoid follicles here.
Lymphoid follicle.
Okay. So in between the follicles, between the interfollicular area, you are finding abundant apoptotic debris, necrosis, and all these are
Yes.
apoptotic bodies. Okay. So as you can see here in this screen, if you can see, this is a very beautiful presentic histiocytes. So many histiocytes, apoptotic debris, and it is lacking neutrophils or eosinophils.
Yes,
I agree with you that some cells do look suspicious for Reed Sternberg cells, but most of them, they are either immunoblasts or some endothelial cells, prominent endothelial cells. Okay, so there were no much of a atypical cell to be noticed here. Although that some immunoblasts can look very prominent, you also need to consider some lymphomas also while you're interpreting at this level. Okay, so most of the findings are that we are not finding any well-formed granulomas. Okay, so predominantly you can see this necrosis, apoptotic debris, and many crescentic histiocytes and some foamy histiocytes. So to summarize your findings, we can so when we see this type of picture, we do basic B and T marker, the T markers. CD3 is the T marker which we have done here, and in slow power you can appreciate that the predominant population is positive for CD3. Okay, in higher power also you can see that many of these cells are positive for CD3. So other marker is CD20, which was provided to you, and you rightly pointed out that those preserved germinal centers are positive for CD20, while the rest of the population or the lesional cells are negative for CD20. So this is a T-rich infiltrate which has numerous apoptotic debris and histiocytes with some immunoblasts or some prominent cells. Okay, so now we can go to the presentation. Your differentials were spot on. Okay, so we have the same slide which I'm showing again. We have this preserved germinal centers and large areas of necrosis and apoptotic debris. It lacks neutrophils and eosinophils and clear atypical cells. So this is one pointer which is going for the crescentic histiocyte. So this is indeed all the cells are positive for CD3 and the germinal centers are positive for CD20. So this is indeed a diagnosis of Kikuchi-Fujimoto's disease. So to summarize the population, the physiological features, we are finding abundant karyoretic debris, crescentic histiocytes with some lymphocytes and immunoblasts. There are no granulomas, no markedly atypical lymphoid cells. So the predominant population is CD3. So one important thing which all of you should remember is before giving a diagnosis of Kikuchi, kindly rule out tuberculosis and any other fungal infection. So AFP should be negative for all these cases. So we know that Kikuchi-Fujimoto disease, it is a rare cause of necrotizing lymphadenitis. It was reported nearly 50 years before separately by Kikuchi and Fujimoto in Japan. It is also called as histiocytic necrotizing lymphadenitis. Okay, all three are explanatory, self-explanatory. So it is commonly seen in young adults. The mean age of presentation is 21 years. Initially, the prior studies were having female preponderance, but most of till date literature, there was a observation that the male to female ratio is equally distributed. So even males can be equally affected. And the presentation includes cervical lymphadenopathy with constitutional symptoms like fever, night sweats, and a prior history of URI or ongoing upper respiratory tract infections. Along with this, the biochemical profiles include the patient will have anemia, increased LDH, LFT, ESR, and there can be few circulating atypical lymphocytes. So, in addition to that, what do we see in the biopsy? It all depends on the stages of Kikuchi. Can you tell us what are the stages of Kikuchi?
The proliferating stage, necrotizing stage, and third one is granulomatous.
The xanthomatous phase. Okay.
Xanthomatous,
Either you can say stages or phases. Okay. So when it is proliferating, it looks really bad sometimes. It can be confused with your peripheral T-cell lymphomas, lupus lymphadenopathy, and cat scratch disease. So here, what are those cells which are key in identifying the Kikuchi disease? Is the plasmacytoid dendritic cells. Okay, these plasmacytoid dendritic cells will have pale cytoplasm. Along with that, we'll have these atypical lymphoid cells, macrophages, apoptotic debris. Unless you identify these apoptotic debris, it will be difficult to diagnose Kikuchi disease. You have to be very vigilant, and we have to correlate with the clinical findings as well as the IHC findings. So in the second stage, it will mimic a tuberculosis. So we can see this geographic necrosis. As we had previously discussed in the other case, there can also be geographic necrosis here. So after some stage, the necrosis will be gradually replaced by these foamy histiocytes, where we can find only xanthomatter cells. In our case also, we have found some xanthomatter cells here. So it is most dangerous and notorious in the proliferative phase, where diagnosis of PTCL needs to be excluded or needs to be considered also. So this is a benign condition, self-limiting condition. Because can you do any further IHCs on this? Have you read anything about this?
Yes, sir.
Kikuchi?
Yes, sir. CD60, CD63, 68, CD123, and CD30, sir.
Okay. So CD30 is an activation marker, okay, which can be seen in many conditions. So it is such a proliferating condition. Obviously, CD30 positive immunoblasts and cells will be seen, but it won't point you towards any particular direction. In fact, if there is plenty of CD30, you will confuse it with Hodgkin lymphoma, but you have to take it together, okay. So in the subset, that is CD3 positive population, we do CD4 and CD8. In Kikuchi's disease, there is predominance of CD8 positive population because that is key to the pathogenesis of Kikuchi disease. So CD68 is a marker of histiocytes, and very classic about is that there is expression of MPO in these histiocytes. What is MPO? MPO is myeloperoxidase. Okay, so you can see that the histiocytes are positive for CD68 and MPO, and CD123 highlights the plasmacytoid dendritic cells. So most of the times we don't do much of IHC. We are the morphology as well as basic immunohistochemistry is enough for the diagnosis along with clinical correlation. Okay, so Kikuchi disease is a benign and self-limiting condition. The time limit which can take for resolution can range from 1 to even 6 months also. But ultimately it has to resolve by itself, or some support treatment might be needed. The exact etiology is not known till date, but it is considered as a autoimmune process which is against a initial viral trigger. So the viral triggers which were hypothesized are Epstein-Barr virus or human herpes virus. So it is an exuberant T-cell mediated immune response in a genetically predisposed individual. So it can be a variety of non-specific stimuli also. So that is why the initial viral prodrome and the other constitutional symptoms were also present for this patient. So as you said that even lupus lymphadenopathy can be considered as a differential. For example, if the same biopsy slides are given in a setup of lupus, patient ANA is positive and the patient has other symptoms also. So this can explain very well the lupus lymphadenopathy. And apart from seeing the basophilic material which is present in the blood vessels or in LD bodies, the hematoxylin bodies, it cannot distinguish, and even it is not a very specific condition. So there can be significant morphological overlap between Kikuchi disease as well as lupus lymphadenopathy. So now comes the element of clinical as well as biochemical correlation. So there is rare association even. So this patient has Kikuchi has resolved, and for some time the patient can develop lupus SLE also. So there can be some rare association between SLE and Kikuchi disease, and definitely morphological overlap. Okay, so what is the mechanism of cell death in Kikuchi disease? As I initially said, CD8 is the key cell in mediating this disease. It serves as an effector as well as the target cell. So effector as well as target cell means it is the one which perpetuates the pathology. That is destruction of the target cell via two pathways. One is the FAST pathway as well as by using perforin method. So FAST is the death ligand. Okay, the cell will present the death ligand to the cell, which is the target cell, and there is increased perforin and granzyme mediated apoptosis. So there are some studies which have proven that there is co-expression of the FAST and FAST ligand on the CD8 positive lymphocytes, which also express the cytotoxic markers, which means the same cells are being affected and which the one which propagates. So the take-home message is that CD8 positive cells are key in Kikuchi's disease. Okay, so that summarizes this condition, sir. Sir, any comments and from sir and ma'am?
Ma'am, anything?
Yes, thank you, Dr. Bala, for such a lucid presentation on Kikuchi. And sometimes it's giving, just remember that sometimes it gets very difficult to differentiate SLE from Kikuchi, but more dangerous is to rule out a lymphoma. So that sometimes you require IHC to differentiate. Rest, Dr. Bala has covered it in detail. Thank you, Dr. Bala. We can move on to the next slide.
So case 3, who's presenting?
Sir, I am presenting. Case
Yeah,
3,
good
an
name.
elderly gentleman presents with bloody stools.
Yeah, what's your name? Sorry, I can. Gata. Okay, fine.
So case 3, an elderly gentleman presents with bloody stools and abdominal pain. Colonoscopy reveals multiple ulcers. He has received stem cell transplant 2 months back for multiple myeloma.
Okay. So from the history, you want to think of something? Okay, so before that, we'll just see the
2 months back.
histology. Okay. So can you please describe?
Yes. So the study shows fragment of colony nucleus and the mucosal shows that
I think we are
and
finding some
clumping
difficulty
with
with you.
cryptitis
Your
and folk.
voice is breaking. Agatha, your voice is breaking. So please present very slowly.
Yes,
Yeah.
sir. Yes.
Yeah.
Yes, sir. Section studied shows 2 fragments of colonic mucosa with focal denudation and sloughing, with cryptitis and focal crypt abscesses. Also noted are numerous mitotic figures and apoptotic bodies in the crypts. The lamina propria shows inflammatory infiltrate comprising of lymphocytes, plasma cells, neutrophils, occasionally eosinophils with histocytic collections. Also noted are areas of fibrosis and ill-formed epithelial collection.
Okay. So what are your differentials?
There are numerous apoptotic bodies in the crypts and cryptitis,
Okay.
so there can be graft versus host disease.
Okay. Good. So some of the findings which might not be that much present are these cryptitis and crypt abscesses, because it's a very specific terminology which you are using. Okay, so we can't use that word very loosely. Cryptitis and crypt abscesses means, can you define us what is cryptitis and crypt abscess?
So if it's present in the like the epithelium, the lining of the crypt, it is cryptitis. If it is present
Which
in
is
the lumen,
present?
it is crypt
Which is
abscess.
present?
If the inflammatory cells are present in the
Which inflammatory
neutrophils,
cell?
in
Can you
the
be very
lumen, it
specific?
is neutrophils.
Neutrophil. Okay. So I couldn't find any neutrophils. Probably you might have seen the mitosis or lymphocytic or apoptotic debris and considered this as neutrophils. So as you said, most of them. So we have this colonic mucosa. We have 2 fragments here, as you can see, and there is denudation of the mucosa. Okay, and there is mild crypt distortion. Okay, the direction of the glands which are flowing are slightly distorted, and the lamina propria is moderately inflamed, comprising of lymphocytes, plasma cells, and few eosinophils. So many of the scripts are showing brisk mitotic activity. As you can see here, do you appreciate the mitotic figures? Okay. So this means it is a regenerative activity which is happening. Something is damaging the crypts and they're actively regenerating. And many of the crypts are showing these apoptotic debris. Okay, apoptotic bodies are apoptotic debris. But it hasn't much transformed into crypt rupture, crypt abscess, or granuloma formation. This patient has received stem cell transplant, so patient would probably be on immunosuppression, right?
Yes, sir.
Do you want to look anything else? The patient is having loose stools post transplant. Do you want to look at anything else?
We can look for cytomegalovirus inclusions.
Cytomegalovirus.
They are
Yeah.
common.
So we have to look out for cytomegalovirus inclusion. Where do you want to look for that?
The endothelial cells.
Okay, you have to look in the endothelial cell as well as the stromal cells. Did you find any? No. Okay, so that becomes a very important negative finding here. Okay, So cryptitis and cryptapsis also might, in this case, it's not there. Okay, so we can go back to the presentation. So the clues were clear in this case. Okay, the patient has received transplant for multiple myeloma 2 months back, and is presenting with bloody stools. And you can see in the slide there are multiple foci of apoptotic bodies. However, there is no complete destruction of the crypts. Okay, so and there are multiple mitotic regenerative activity within the crypts. So there is crypt distortion, lamina propria moderate inflammation, no CME inclusions, there is crypt apoptosis and regenerative activity. So these findings are compatible with the acute graft versus host disease grade 1. So we need to grade the disease which is happening. That will be helpful for the clinician, and it indicates the level of injury which has happened to the patient. Okay. So can you say a bit about GVHD? Just few points.
Sir, it can be acute or chronic, and it is actually it's because of the donor T cells which are destroying the recipient cells, and it can be acute or chronic. Within 100 days is acute, and succeeds it is chronic.
Okay. Good. So we just briefly see what is GVHD. GVHD means graft versus host disease. It is the most important complication post hematopoietic stem cell transplantation. It is as high as even 50% of the cases. So what happens is we have a normal immune system, and the normal immune system is able to reject the T cells from a foreign donor. Okay, but when the recipient's immune system is compromised, because before doing the stem cell transplant, they will try to suppress the immunity of the patient so that whatever stem cells which they are giving will have to be engrafted with the recipient, and they use immunomobility agents for that. Since that leads to the compromise in the immune system, and the body is not able to reject those donor T cells. Okay, so what are the important prerequisites for a GVHD? The transplanted graft must contain immunologically competent cells like bone marrow or stem cell transplant. So this GVHD is seen very less proportion in solid organ transplant. Okay, that means the proportion of getting GVHD via a solid organ transplant like a kidney or a liver is very low. Okay, so second is the recipient must be capable of rejecting or eliminating the transplant cells. Must be incapable. That means, yeah, the immune system should not be very active. If it is there, then initially that the immunity can take care of those foreign T cells. Okay. Third one is they should express the tissue antigens that are not present in the transplant donor, so that the cell will be considering them as the foreign cells. Okay. So these are the three important prerequisites for a graft versus host disease. Okay. So as you initially said, it is arbitrarily classified as acute and chronic, as a 100 days as a arbitrary mark. But now, practically speaking, they are considering that the acute presentation can be even seen after day 100 also. Okay, so this arbitrarily may not hold true practically. So what are the important organs which are affected in GVHD? Can you tell us? As it is mentioned here, it is skin, GIT, and liver. So whenever a patient is undergoing GVHD, it may not be restricted to just GI tract. Okay, that will be in the skin as well as in the liver also. So there are it's a 3-step process to explain what actually happens to the patient. The initial response is the conditioning mediated tissue damage. Second one is the donor T cell activation. Third one is the target cell apoptosis. So the first step is conditioning mediated tissue damage. So what do you mean by conditioning? Conditioning means using various therapy, we are trying to eradicate the underlying disease and to support the engraftment of the donor cells without rejection by the recipient. That means, for example, if the patient has acute leukemia or Hodgkin lymphoma or any other disorder where you need to kill the cells which are pathological first, then you have to that our donor cells will go and engraft in the recipient. So during this condition, this chemo, radiotherapy, as well as the regimen which we are giving to the patient will also elicit host tissue damage. Once this host tissue is damaged, there will be release of the antigens, various antigen. There will be transposition of the lipopolysaccharides from the bacteria via the leaky gut, and which in turn leads to the activation of MHC antigen upregulation, and the antigen presenting cells will be homing with this antigens. So once the donor T cell identifies these antigens, there will be proliferation of these T cells, which further lead to end organ damage. So this picture is indicating, this diagram will illustrate the GVHD. Here is the recipient conditioning. So there is either radiotherapy, chemotherapy, and which leads to the damage to the host tissue. There is transposition of the lipopolysaccharides, which is scavenged by the macrophages. So whenever there is a damage associated molecular patterns, there will be activation of this macrophages and release of interleukins and TNF alpha. So this dendritic cell will act as an antigen presenting cell to the donor T cells. This is called as a direct mechanism. Okay. So this direct mechanism, indirect mechanism is the one, donor T cell, which directly, which goes and absorbs the realizes and the antigen, which is not via the antigen presenting cells. So by these two methods, two ways, the donor T cells are activated and there is proliferation. Okay, so the cells become activated via the interleukin 2 and interferon gamma. The third step is the effector phase, which we are seeing as the histological features of GVHD. It damages the gut, skin, and liver. So what are the ways through which it damages? The usual pathway, initial two pathways which we saw in the previous case. Okay, it can be either by the expression of death ligands or via the perforin granzyme pathways. The third one is it can also damage to the cytokines. Okay, so these are the three. This is the pathophysiology behind GVHD. Okay, so before considering the GVHD, we'll just see the grades of in colon as well as some other things. So there is a grading called Lerner's grade. So there are rare apoptotic bodies without any crypt loss. This is grade 1. Grade 2 is loss of individual crypts. Grade 3 is 2 or more continuous crypts are lost. And in grade 4, which is the highest grade, that means there is complete mucosal ulceration and you can't identify any crypts, residual crypts. So some illustrations here, you can see that this is the crypt, and you can find many apoptotic bodies which are present. Okay, and this is the grade 2. You can see that there is destruction of the crypt with little formation of simplification of the epithelium and loss of the crypts. And grade 3 is the more than 2. You can see the space between these two crypts. So there will be like 3 or 4 crypts which have already been lost by this pathology. And grade 4 is complete ulceration, and there is virtually no crypts which are present. Okay, so this is the histological features of colonic GVHD. Before considering GVHD, what are the other conditions which should come in your mind before giving the differential? If this patient presents with GVHD-like symptoms before 20 days, that is initial 20 days, you have to think that even the conditioning regimen per se can cause the epithelial cell apoptosis and increased mitosis. Second one is the CMV inclusion, which we discussed, which is very important to identify. And the third one is cryptosporidium, that we can identify in histology because there will be like small basophilic structures which will be coating the mucosal aspect. That is cryptosporidium. And one important drug which can cause, which can mimic GVHD is MMF, that is mycophenolate mofetil, which can cause apoptosis and ulceration and laminoproprial inflammation. So how can you distinguish MMF versus GVHD is MMF will cause apoptosis only in the colon, okay, and the skin and the liver won't be involved in that, and cessation of MMF will lead to resolution of the clinical symptoms from the patient. Other one condition is the routine use of PPI, which is given to the patient normally. So using PPI, proton pump inhibitors, can cause this apoptosis, but it will be restricted to the gastric mucosa. It won't be usually involving the colon. Okay. The last one is the cord colitis syndrome, where you give cord blood for transplantation, and which can lead to similar symptoms. Okay. So in addition to all this thing, you have to also consider infectious cause. Okay. So if the infection is being resolved by antibodies, that means that it is probably infectious. So these are a few of the DDs. Here, this is a skin biopsy from a different patient with suspicion of GVHD. Here you can see that. Can you appreciate? Are you able to see the screen? Kata?
Yeah, we can see.
Okay. So here you can see the epidermis, and you can see there is formation of multiple apoptotic bodies. Thus, you call them as Civate bodies. Okay, these are the eosinophilic bodies which are present here, and in fact, it is in a higher stage. There you can see there is clefting of the epidermis also. So notoriously, GVHD in the skin can lack significant inflammatory infiltrate. So one important clue is the involvement of adnexal structures. If there is formation of inflammation deep into the adnexal structures, and presence of this multiple sevative bodies, we can consider that these are the histological features of a skin GVHD. Okay, so this is to just summarize the cases. Okay, so sir, any comments on ma'am?
Ma'am, anything to add?
No, very nicely taken. In fact, you described the skin also. So one feature which you should note for GVHT is the residents should see if you don't see any neutrophils, then think of, and there is a history, then you can see the apoptotic bodies, so go for GVHT. That's the only thing which I feel is, if you're not seeing any inflammation and you're seeing ulceration and apoptotic bodies, think of graft versus host disease. Thank you, Dr. Bala. Let's move on to the next
Thank you, ma'am.
one.
So next person.
Dr. Subarashni Sakya. I'll be presenting case number 4.
Subhashni, please read out.
The history of the patient is she is a 35 years old female who has presented with insidious onset of fatigue and gradually progressive jaundice. She is not alcoholic and her baseline investigations are given as below. She had high indirect bilirubin. Her all AST, ALT, and ALP enzymes are elevated except GGT, which is normal. Her total serum cholesterol is normal. Triglyceride levels are normal, but ANA is positive with a titer of 1:160. The viral markers like hepatitis B and C and HIV is negative, and it said that within few days of admission, the patient has developed liver failure.
Okay, so okay. Can you please interpret the clinical parameter? Can you put it together? What do you understand from this values?
Yeah, first of all, the patient is in a reproductive age group, and she is having a insidious onset of fatigue. So it looks like something chronic, and plus she's not alcoholic, and her indirect bilirubin is increasing more. That gives a intrinsic pathology involving the liver.
Okay.
Her all enzymes are also dearranged, and her ANA is positive. So it kind of points towards autoimmune disease.
Okay. So
And,
this AST ALT values, though they are normally in 30s, right? If it is in 700s, 530, so it's, can you just correlate with the amount of injury which has happened initially? Is it a massive injury or moderate or mild injury? Can you tell?
massive injury because all the especially ASTs more than 5 times we have increased.
Yeah. So this was the baseline investigation. Okay, just to give you a reference value, if it is in thousands, generally,
Yes.
that means it's an ischemic process. Okay, this is just an additional point. So this is an hepatitic picture which is happening in a female and with increased ANA. As the most of the clues are given in the history, just to point you towards the right direction. Okay, so we can just okay, just a minute. Just okay. Can you see the screen?
Yes, sir, I can see the screen.
Please, can you just briefly present? No need to, be so formal. Okay, just casually present. Okay.
The section from this multiple linear co-biopsies of the liver are showing me extensive areas of pericentral and periportal inflammatory infiltrates of chronic inflammatory cells.
Okay.
And with this, you can also see some interface hepatitis.
Okay,
And
good. Very good.
along with it, I can see certain areas showing microvesicular changes
Okay, fine.
with ballooning degeneration, and also there
Very
is
good.
some amount of apoptotic bodies are also noted,
Mhm.
and I can also note some amount of ductal reactions can be seen in
Very
focal
good.
areas. Even blood formations by hepatocytes can also be appreciated, and I have
Okay.
noticed a separated focal area of necrosis in the slide, sir.
Okay, fine. Mhm.
All this point towards a chronic hepatitis. Maybe disease, I'll be putting autoimmune hepatitis first, and it can also be caused by drug-induced hepatitis.
Very good. Okay. So what are these structures? Which am I pointing to?
I can't.
Ducts.
So yeah,
Okay,
that's
these are the bile ducts.
these
Okay.
are the bile ducts, sir.
Okay. So one thing is both kidney and liver, you have to go systematically. Most of the findings are very well presented. So we just say the number of cores which are present, whether there is adequacy or not. Yeah, it is adequate. Hai na? And second thing is you either go for the first you go for the architecture. Okay. So do you think there is architecture is maintained or there is any loss of architecture in this?
So there is a loss of architecture because I cannot appreciate on the hepatic lobules properly, but the core is
So there is
liquid
loss of architecture with formation of irregular nodules. So no, that is the first thing we should say. Okay, then you go to the portal tract. Okay,
Yes,
there is expansion of the portal tract. Okay, with dense lymphoplasmacytic inflammation, and there is extension into the limiting plate. That is the interface hepatitis. Then you further expand on the portal tract. You can see that this is a hepatic arteriole. These are the proliferating bile ducts, and this is the portal vein. Okay, so this you can see that there is increased inflammation in the portal tract with interface hepatitis. As you rightly pointed out, there is large areas of necrosis here. Okay, so this arrow is placed here to say that from this end to this end, there is loss of hepatic parenchyma. In between, there is only one portal tract. So there is quite a loss of hepatic parenchyma, which indicates there is necrosis. And so the bile ductal proliferation is happening as a consequence of the injury, as well as a probable element of obstruction which is there, which is causing this bile ductal proliferation. So you need to mention more about the hepatocytes also. Okay. So what am I focusing here?
so that's
Anybody else can say?
apoptotic.
Yes, somebody said that. What? This is spotty necrosis. Okay, so you find a the hepatic parenchyma. There is loss of hepatocyte which is surrounded by this inflammation. So we are finding multiple foci of spotty necrosis. So as we go on the description, you have to see the extent of the inflammation which is present. So it is predominantly present in most of the portal tracts. Okay, and this is just to point out the other portal tract, just for the juniors to identify the various structures of the portal tract. This is a nice bile duct, and this is the portal vein, and this is the hepatic arteriole. Okay, you can see that this is quite fibrosed and the inflammation is extending here. And interface hepatitis also I already showed. Okay, so we are finding multiple foci of spotty necrosis, and there is a lot of necrosis here. Coming to the hepatocytes, can you just tell us what is this structure?
So this is a microvascular hepatocyte.
No, so these are ballooned hepatocytes.
Balloon, sorry, balloon
Okay, so
generation.
these are ballooned hepatocytes. Probably this we are referring to as microvesicular steatosis. So this patient, generally microvesicular steatosis, unless it is like diffusely present or in some special conditions, we don't emphasize much on that. Okay, some of them are showing some giant cell transformation, yeah, and there is a
Yes.
minor element of cholestasis which is present in few of the foci. Okay, so just to show you the, I'll just toggle here 1 minute. Okay, we saw that there is ballooning, yeah, balloon hepatitis which is there, and we also found the multiacinar necrosis. So in between parenchyma, there is loss of hepatic parenchyma, and some of the preserved hepatocytes are showing these changes. Spotty necrosis, yeah, which I showed. All of you should be able to appreciate, and this is the bile duct injury which is happening. When I'm gonna see the portal tracts, you have to assess all these features. Okay, so can you tell what is limiting plate?
Surrounding the portal tracts, the first layer of hepatocytes are known as the limiting plate.
Okay, why is it important?
If the limiting plate is crossed by the inflammatory cells, then it goes for interface hepatitis.
Okay, so very good. So this is the most important feature of autoimmune hepatitis. Okay, so we have found interface hepatitis, we have found portal tracts. Okay, so quickly we go through the special strains. Okay, what is the special strain?
So this is Mason's trichome. Okay.
Mason's trichome. Okay, so why MT is done for what?
It's done for to identify collagen or connective tissue in the.
Okay, so it is specifically for type 1 collagen. Okay, again for the juniors to appreciate, this is a portal tract. There is quite an expansion of the portal tract. This is the bile duct, and this is the portal vein, and one more hepatic arteriole, smooth muscles of the hepatic arteriole is present here. Okay, so there is expansion of the portal tract. So as you were saying that it is used to assess the architecture, overall fibrosis of the liver. You can, in this case, you can see that there is formation of nodules. Okay, and we say that they are incomplete or complete nodules because you also need to stage the pathology. Okay, that will tell you the what is the long-term consequence of this patient. Activity will indicate how virile this pathology is, but the chronicity part, which is important because that will tell the long-term prognosis of the patient. If this patient has cirrhosis, then they have to work up for starting for a transplantation. Okay, and its stage 6 is quite irreversible. So the portal tracts and the nodule formation is highlighted here. one additional benefit about having MT is that so this hepatic necrosis which I initially showed, can you appreciate the color difference here? This is the portal tract. This is the normal portal tract. You can see this is quite nicely blue, and here where there is necrosis, this is slightly grayish. So this indicates that there is loss of parenchyma here. Ideally, you need to have Orsin stain to see that if there is lack of elastin fibers which is present in this, that will be able to distinguish the true collapse from passive collapse. Okay, so what is this stain?
Reticulin stain.
Okay, what does reticulin highlight?
Type 3 collagen, sir.
Type 3 collagen fibers. So reticulin fibers are between every hepatocyte that forms the architecture of the liver mostly. So this is the single plate thickness of the hepatocytes which are present by the reticulin fibers. Normally reticulin should be crisscrossed. Okay, it has to be crisscrossed and it cannot be mostly parallel. Okay, if it is parallel, that means there is some pathology. Whenever there is hepatocytic necrosis, what do you call them as? There is condensation of reticulin fibers. Okay, that indicates that there is collapse of the hepatic parenchyma, and that leads to the condensation of the reticulin fibers. As you are appreciating this case, this is where I placed the arrow. If you can recollect, between the two hepatic parenchyma, there was this loss of reticulin fibers. I mean, there is compression of this reticulin fibers, indicating the hepatocytic necrosis. What is this stain?
This is paritic acyclic stain.
Okay. Why do we do that?
So it was done to identify to see the glycogen stores of the liver.
Okay, good. And also it will highlight the Kupffer cells between the hepatocytes. Then also the macrophages which have scavenged the whenever there is any apoptosis or any cell death, you will find some fast positive materials which is in the macrophages in the portal tracts. Okay. Other thing is alpha-1 antitrypsin material. Okay, it will be diastase resistant. That is also just a pointer. Don't forget to mention that. Okay, these are the advantages of PAST. So just to summarize the findings, so this is hepatitic picture, and one thing which I mentioned here, this within few days of admission, the patient has suffered liver failure. That means something more detrimental has happened to the patient. Okay, so description and you are given the diagnosis. Just to quickly review here. So the acini forms the functional unit of liver. This is the portal tract here. This is the central vein, and this is another portal tract here. So what you call this area is the you can either say it is zone 1, zone 2, zone 3, or you can call it periportal, midzonal, and centrilobular. Okay, so there are different pathologies which can affect the different areas. I don't want to go into the depth of that, but this you can understand that this is the most this is the area which is most susceptible for hypoxic injury and many drug-induced injuries. Okay, because it is the least oxygenated area, because the flow of the oxygenated blood is from towards the from the portal tract to the central vein. Okay. Another thing is this is the limiting plate hepatocyte, which you have initially mentioned, that this sharp demarcation between the portal tracts and the hepatocyte is very important, because if this is obliterated and the inflammation is spilling into the hepatocytes, that means that there is interface hepatitis. Okay, so these are some important points. So to summarize our histological features, we have architectural distortion with nodule formation. There is portal tract expansion by mixed inflammation comprising of lymphocytes, plasma cells, and few neutrophils. So one thing I just wanted to tell you is that normally we don't see neutrophils in portal tracts. Okay, especially when you see neutrophils in the bile ducts, that one can also think of an ascending cholangitis and inflammation also associated with that. Okay, so interface hepatitis, which I clearly showed that there is this extension of the inflammation to the inflammation extension as well as the destruction of the limiting plate of hepatocytes, and it was present predominantly in most of the portal tracts. Okay, so you need to identify the lesion, simultaneously you have to quantify it, because we have a score for that. Okay, so then there is ductular proliferation and bile duct injury as demonstrated. The hepatocytes show varying evidence of inflammation in the form of spotty necrosis, confluent necrosis, and ballooning degeneration. So this ballooning degeneration is also a form of hepatocytic injury. Okay, so the diagnosis which you need to write in your exam as well as in your mind is that we have chronic hepatitis with superimposed acute hepatitis. As you rightly said, drug-induced hepatitis, the drugs can mimic any condition. It can literally mimic each and every condition which is mentioned. Okay, so a prior history of any intake of native medicine or CAM and cessation of the drugs which leads to resolution is also equally important. So the important differential here, which has helped to clinch the diagnosis, the presence of auto antibodies. Okay, NA and other auto antibodies. So we follow a scoring system to quantify this injury. that is the Ishak's modified histological activity index scoring, which we'll see now. This is the highest score which is possible here. So just we'll quickly see the grading, high grading. So we have A, B, and C, A, B, C, and D. In A, we use periportal inflammation, also called as piecemeal necrosis. Okay, these are the prior terms which we initially used. In that, we have score from 0 to 4, 4 being the most severe form of injury, where there is the inflammation is, the interface hepatitis is continuous and it is more than 50% of the portal tract. Confluent necrosis means, as you initially saw, that there is loss of more than the hepatocytic necrosis. We classify them based on the number of areas. So first one is the zone 3, when there is only perivenular necrosis, and in some areas, most areas, when and along with that there is formation of portocentral bridging. Okay, so in score 5 we have zone 3 necrosis with multiple portocentral bridging, and there is pan-acinar or multi-acinar necrosis in as score 6. So we also saw from one portal tract to another portal tract, we found out large areas of necrosis. So we are given the highest score here. In case of focal lesion, that is the spotty necrosis, we found multiple foci. We assess this in a 10x objective. Okay, one foci or less than in one 10x objective, 2 to 4, 5 to 10, and more than 10 objectives. Highest score is 4. The third one, the last one is the portal inflammation. The portal inflammation is mild, moderate in some areas, and moderate in all portal areas, and marked in all portal areas. So, like in our case, we found maximum inflammation in most of the portal tracts. So, based on this, so when you do this, we usually keep a printout of the scoring in the in the reporting room, and we score based on that. Okay, and this is the activity necroinflammatory scoring. This we give out of 18. And for the chronic component, that is the fibrosis and cirrhosis component, the same thing, 0 to 6. So in so the early fibrosis, we can identify only using special stains like Mason trichrome. After that, we can, as the fibrosis will expand, we can even identify in the naked eye, but you should use Mason trichrome stain to confirm your diagnosis. Okay. So as the scoring increases, the last score is the cirrhosis. Okay. So one is the fibrous expansion of some portal tracts with or without short fibrous septae. Most of the portal tracts is score 2. Third one is the most of the portal tracts with formation of portal bridging. And in addition to portal bridging, if there is portocentral bridging, then you form it as score 4. Score 5 is formation of incomplete nodules, and cirrhosis is there is formation of complete nodules. Okay. Sometimes in core biopsies, you may not see the entire complete nodule. If you see the complete nodule, then it is well and good. Okay. If you don't see, then we can score for maximum score 5. Okay. So before that, these are the findings which we already explained in Mason trichrome and the reticulin fibrous condensation. Okay. So the important key features for autoimmune hepatitis are portal lymphoplasmacytic infiltrate, interface hepatitis. So this is the limiting plate of hepatocytes, you can see, and this is the portal inflammation. So this portal inflammation will extend into the limiting plate with destruction of the hepatocytes here. So the so-called the most important very classic finding which they used to initially tell was the presence of hepatocytic rosettes and emperipolysis. What is emperipolysis?
Entry of one cell to another or eating up of the other cell to one.
So it will be intact. The lymphocyte will be present intact. So later studies have found out that these are not very specific for autoimmune hepatitis. So they have, in the diagnostic criteria, they have removed the presence of rosettes. Or if it is present, then well and good. If it is not there, then it is not not needed. So there is variable lobular necroinflammation we saw in the form of varying scores, spotty necrosis, confluent necrosis. So perivenular, one peculiar pattern in autoimmune hepatitis, when there is you won't find much of an inflammation in the portal tract, but however, there will be perivenular necrosis that indicates a severe disease activity. Also, we will find bile duct injury. Okay. So, can you just tell, also I'll just tell, okay. So autoimmune hepatitis is a progressive immune mediated inflammatory condition, which if untreated leads to chronic hepatitis, cirrhosis and liver failure. Okay. So without treatment, this will eventually go for chronic hepatitis, fibrosis and cirrhosis and liver failure. So this is more common in females. The ratio is 1:4 and to up to 1:6. The presentation can be variable. Like it can start, non-specific abdominal complaints. There's isolated elevation of AST/ALT during routine checkup, and it can even have an acute presentation in the form of perivenular necrosis, or it can rarely present as cirrhosis. So we need a combination of clinical, laboratory, and histological features for the diagnosis. So sometimes there can be association of autoimmune hepatitis with the primary biliary cholangitis as well as the primary sclerosing cholangitis. So PBC, PSC, then we call it as overlap syndrome. Okay, so these are chronic cholestatic disorders which can be associated with AIH. I don't want to go into the depth of this. Okay, so we can see briefly about the pathogenesis of autoimmune hepatitis. So in your Robbins chapter in autoimmunity, you should know that like any other autoimmune disorder, there are the multitude of factors which causes autoimmune hepatitis. The first one is the genetic predisposition, the presence of various HLA, DR3, DR8, and many HLA types are genetically predisposed for autoimmune hepatitis. And there is decreased tolerance. Tolerance means the self antigen recognition. Okay, the ability to identify the one's own antigen as self. And if there is lack of the tolerance, then that causes the immune system to respond on that. Any environmental toxins, any triggers, UV exposure, stuff like that. Individual risk factors, sometimes even drug can cause inside defectors, and any viral infections can also trigger this. So a multitude of factors which can influence will cause autoimmune hepatitis. There is dysregulated apoptosis, HLA modification, molecular mimicry, altered T cell regulations, formation of neoantigens, and antigen release. So this is multiple factors which can trigger autoimmune hepatitis. So for diagnosis as well as types of autoimmune hepatitis, please refer to this table. So we have two types of autoimmune hepatitis. One is type 1 and type 2. It is based on the nature of antibodies as well as the clinical profile. In type 1 autoimmune hepatitis, there is ANA, anti-nuclear antigen, anti-nuclear antigen, anti-smooth muscle antibody, anti-actin antibody, anti-SLE, that is soluble liver antigen, and liver pancreas antibody. Okay, so these are the types of autoantibodies which are present in type 1 AIH. Sometimes in 25% of the patient there can be negative, ANA can be negative. So we call them as seronegative autoimmune hepatitis. Okay, so in type 2 we have anti-LKM. You know what is LKM?
Liver kidney microsomal.
Liver kidney microsomal antibody, and LC1 is liver cytosolic 1 antibody. Okay, these are the type 2. So the difference between type 1 and type 2 is that type 1 will be present can be in all ages, whereas in type 2 it is usually restricted to the childhood and young adulthood. The sex ratio is very high in type 2 autoimmune hepatitis. It is 3:1 in type 1 autoimmune hepatitis. So the clinical phenotype, response to treatment, recurrence, all are worst in case of type 2, whereas it is favorable, mildly favorable in case of type 1 hepatitis. So before diagnosis of AIH, what do the clinicians do? This is the scoring which you do, point-based scoring which you do for autoimmune hepatitis. So what is the serum titer of ANA and or SMA? If it is more than 1:40, that is you give score 1. If it is more than 1:80, you give score 2. If there is any presence of LKM1 more than 140 or SLE, you can use the same scoring. Any titer of SLE can be used. So so you also do the IgG level. It will be increased more than 1.1 times normal, but then you'll give score 2. Okay, so the liver histology, we say if it is compatible with AH or typical of AH. If you find all the features which I clearly mentioned, then it becomes typical of AH. However, there are some findings which are not able to, which are not present or not able to completely fit in. There is mild inflammation. There are some foci of interface hepatitis, and there is not much of necroinflammatory score in the hepatic globules. So that time you'll say compatible with AH, kindly correlate with serology and the other clinical parameters. Another important thing is they do viral hepatitis workup for all the patients who are coming to the gastroenterology OPD. So it has to be absent. Okay, so if it is present, then obviously it will reduce the score for that. There can be even combined one, but for discussion sake, we can assume that the patient will be not having viral hepatitis. So if there is more than 6 points, it's probably AH, and if it is more than 7 points, it is definite AH. Okay. So other complicated things are like seronegative autoimmune hepatitis and stuff like that. So for your level, this is more than enough. If you can remember this, I'll just briefly go through the pathogenesis, how actual AH happens. The first one, initially we saw the environmental triggers. It can be either viral infections or any other drugs or something like that. This can damage either the hepatocytes or the cells which are also present in the liver. That is the Kupffer cells or the endothelial cells. All these three can be damaged. The antigens will be exposed after that. So what the initial action will be by the resident innate immune cells. Okay, the resident innate immune cells, that is the macrophages and the dendritic cells, will analyze or will process this antigen, and there will be release of this pro-inflammatory cytokines like interleukin 1 beta, TNF, and INF alpha. So the initial recruitment will be non-specific. Okay. After that, what happens is there is release of this interleukin 4 and interleukin 12. So there is persistence of this interleukins. Then there will be recruitment of the liver autoantigen specific T cells. Okay. So now initial response was non-specific. There is innate process, and then there will be presence of the specific immune process. So after that, the actual work starts. That is, if there is expression, there is increased CXCL9 and CXCL10, that will lead to the maturity of the Th2 cells will secrete interleukin 4 and interleukin 10, which will in turn activate the B cells. The B cell will be transformed to plasma cells, and it will secrete the autoantibodies which we initially saw. So this is one pathway. And then what happens to this antibody is that they will be coating the hepatocytes. Once there is antibody coating, it can damage the cells via complement activation or NK cell mediated damage. So this is the Th2 pathway. In Th1 pathway, there is recruitment of the CD8 positive cells. So once CD8 positivity cells, which we initially saw, there can be cytotoxic mediated damage to the hepatocytes. So this is the active process which is happening. Simultaneously, there will be increase in the TGF beta, transformation growth factor beta, which will lay upon the fibrosis and the chronicity will be developing. So for you, just to remember, there will be initial trigger, the basic first wave of inflammation will be triggered by the resident macrophages. Then there will be proliferation increase in the cytokines. There will be recruitment of specific cells which are, the autoantigen specific T cells will be entering, and then they will perpetuate the injury. So this is the pathogenesis of AH. So, sir, I'm done with this, sir. Ma'am, any questions, sir?
No questions at all. Thank you so much for such a detailed description. I think we should move to the next. Iyer sir, do you have any points, sir?
No, I think let's finish case 5 and 6. then
Okay.
we can-
So next one,
It's me, sir, Dr. Gaurav.
please.
A 30-year-old female presented with ulcer in hard palate and rapidly increasing facial swelling. On examination, the mucosa was ulcerated and necrotic. Histopathological examination and IHC.
Okay. So let's go to the case, case 5, right? Okay.
A section study shows keratinized squamous epithelium showing parakeratosis, acanthosis with mild to moderate dysplasia at places. At places, eosinophilic inclusions are also seen.
Mm-hmm.
And they have intact basement membrane. Submucosa shows infiltration by inflammatory cells like lymphocytes, neutrophils, histiocytes, then plasma-laden macrophages, extensive lipid-laden macrophages, extensive necrosis is seen in some areas.
Okay. Then
At some places, there are clusters of cells which could be hyperchromatic cells, which could be bacterial or fungal colonies. And
okay.
so there's this part actually I'm not sure about.
Okay. So do you think of any, I have given some IHC slides also. Did you interpret them or?
IHC slides, I could see the staining in the nuclei, but of the inflammatory cells.
Okay. So did you come to any differential?
So it could be of B or T cells. So it can be CD19 or 20, 21, 22, or it could be CD2, 3, 5, 7.
Did you think of any differential in this case?
Differentials, or it could be pseudoepitheliomatous hyperplasia. Then because of this, I thought of Wegener's granulomatosis, xanthogranulomatoous inflammation.
Okay, fine. So you did not think of any lymphoma in this case?
Lymphomas.
Fine. So this
it
case I will
could be-
present. Okay. So what the history is that the patient is a 30-year-old female with ulcer in the hard palate and rapidly increasing facial swelling. So this rapidly increasing facial swelling with the ulcer in the young female, some clues are given here. So the mucosa is ulcerated with large areas of necrosis. So I'll just show you the key findings which are present here. So when we generally describe mucosa, we just say that is squamous mucosa. We don't use the word acanthosis in the mucosa. Okay, we use that as hyperplasia. As you that one point which I agree with you is this: there is the pseudoepithelium as hyperplasia of the overlying epithelium. Okay, so this is the bird's eye view of the biopsy. You can say there is large areas of necrosis. That's the theme of this today's discussion. So we have large areas of necrosis here. Okay, additional findings include some bacterial colonies and sort of ulceration which is also present. So coming to the main pathology here, so in the viable areas there is this dense inflammatory cells are there. Okay, they are moderately increased in size with many cleaved nuclei and presence of clear cytoplasm. So this area I was trying to point you to show that this similar type of cells are infiltrating the blood vessels. Okay, this is called as angiotropism. Okay, so what are the other findings which we are finding here is this large areas of necrosis, angioinvasion. Okay, one more foci of angioinvasion is this one. You can see here, it resembles like a blood vessel and where the cells are trying to destroy it. So this is called angiodestruction. Okay, so let's come to the cells per se. So we have a monomorphic cell population which are slightly increased than the small lymphocyte. They are having clear cytoplasm, many multiple apoptotic bodies and mitotic bodies which are actively present with angio invasion, angiodestruction. So this type of milieu, you should think of a lymphomatous process. Okay, this is not just any non-specific inflammation with some ulceration and necrosis. One more differential, as you were saying, is this GPA or granulomatosis with polyangiitis, which can also cause vasculitis and then leading to necrosis of this. Okay, so before that, there is a huge line of IHCs which are given here. So this is a epsilon clone of CD3 which is diffusely positive. Okay, most of the cells are immunopositive for CD3. You can find these cells, Gauri. So this cells you can see many cells are positive for CD3 here. Okay, this is the epsilon clone of CD3. Then this is CD20. What is CD20?
It is a B cell marker.
So if you see the affected area, are the cells positive or negative?
It's positive.
Okay, no. So what when you are interpreting the IHCs for lymphoma, you should always think, you should always see, keep to remember the H&E slide what you saw. These cells are the large cells which are affected here. Okay, so most of the cells, like in this area, if you can see here, like 90% of the cells are negative for the CD20. Only few cells are positive. Okay, so the interpretation of IHCs can be a bit tricky in lymphoma, but you have to do that. Okay, so these are residual B cells which are present. Okay, so these are main tumor cells are negative for CD20. Okay, so this is CD4. The subproportion of the cells, subset of the cells are positive for CD4, unlike many cells are also still negative for CD4. Okay, then this is CD8. Okay, most of the cells are negative for CD8. Okay, so this can be a bit tricky to interpret because you need to actually look at that particular area where you were interpreting the most of the slides. So what we do is generally we see CD3, see the proportion of cells which are positive for CD3. Then we see CD4, yeah, and CD8. So CD8 is nearly negative. Okay, only few cells are coming positive. And CD4, there is some cells which are positive. Okay, so what is this IHC which is labeled as granzyme? You know what is granzyme? Granzyme is a cytotoxic marker. Okay, granzyme, TA1, and perforin are three important markers which we routinely use for the diagnosis of this condition, which we will see now. EBV LMP1 is the Epstein-Barr virus latent membrane protein IHC. Okay, so this is also highlighting many cells which are positive for EBV LMP1. So I'll just put the everything together. So what are the findings which we saw? Overlying epidermis was showing pseudoepithelial hyperplasia. There is large areas of necrosis. There are medium-sized lymphoid cells with folded nuclei. There is this clear cytoplasm of these cells, and there is angioinvasion and angiotropism. Okay, I had shown in the presentation. In addition to that, few immunoblasts and some clay cells were there. So these lymphocytes were positive for epsilon clone of CD3, granzyme B, and EBV LMP1. Can anybody, rest of the students, can they answer? What could be the diagnosis of this?
NKT
May I
cell
ask?
lymphoma, sir.
Yeah.
Extranodal
So-
NKT cell lymphoma.
Very good. Okay, so this is a case of extranodal NK T cell lymphoma. Why everybody should know about this case is that This is a very aggressive tumor with poor prognosis. Okay, the classical features are the angiotropism and the angiodestruction. It expresses cytotoxic markers like granzyme, TA1, and perforin. Some other markers are CD7, which can show variable positivity, CD2, CD56, HLA, DR, and FAS. So the negative markers are CD4 and CD8. But this case showed some expression of CD4. So that's not wrong actually. It can, some cases where there is T cell phenotype, there can be CD4 positivity also. One important thing is this is one of the tumor which is driven by Epstein-Barr virus. Okay, so the marker to bring out the Epstein-Barr virus is the EBER. Okay, EBV small encoded RNAs. We can do in situ hybridization technique to highlight these cells. So it will be diffusely positive in case of extranodal NK T cell lymphoma. And if EBER is negative, then you have to always doubt the diagnosis of extranodal NK T cell lymphoma. So we have JAK3 and STAT3 mutations in 30% of these cases, and anything out of the nose, that is extra nasal sites, have poor prognosis. So the diagnosis is sometimes very difficult because you saw a good chunk of biopsy where both the necrotic part as well as the part where the lymphoid cells were present. And sometimes if the biopsy is done only in the necrotic part, you may not find out this lesional cells. So other important details which can be seen is the presence of any fungal infection, vasculitis, all these things you should know. Okay, so ma'am, sir, any comments, please?
Thank you so much. This is a very important thing which we all must know. And I think we can move on to the last case, sir.
Yes, we can conclude after that about what all we have studied. So let's go to case 6.
Case 6?
Yes, sir. Sir, case 6 is the 50-year-old male presented with symptoms of pleural obstruction and bloody nasal discharge. On examination, an ulceroproliferative tumor was noted, HE and at the SCR given.
Okay, just a minute. Okay, so can you tell us?
Yes, sir. So section shows multiple tissue bits. This is lined focally by pseudostratified columnar ciliated epithelium. Underlying subepithelium shows a tumor, which is arranged in seeds. And individual tumor cells are predominantly round to oval in shape with moderate nuclear polymorphism and scant cytoplasm. And there is rotating of tumor cells around a central zone of fibrillary neural matrix and around central lumen, exhibiting humor and flexion of interest near rosette.
Okay.
There is also perivascular rosette noted in the section, and there is large areas of necrosis. It's apparent in the section examined.
Okay. So what are these?
Sir, on the basis of morphology, we can think of olfactory neuroblastoma might be a possibility.
Okay. So you thought these are rosettes, right?
Yes, sir. These are perivascular rosette.
Okay, fine. Okay. So anything about the mitotic figures?
Yes, sir. Mitosis are, mitotic figures are present, sir.
Okay, so just present is not enough for this case. You see that in this field, literally there are 10,
Yes,
12
prominent,
mitosis.
sir.
Okay, so it's quite
Yes, sir.
brisk mitosis. So
Yes,
if I
sir,
want
brisk
to
mitosis.
summarize from your side, so we have an undifferentiated tumor here. There is it's a malignant tumor. Any doubt? No.
No, sir.
Okay, so you have find the cells have epithelioid morphology, and it has high NC ratio with some scant
Yes, sir.
amount of cytoplasm. There is prominent nucleoli. Okay, at places
sir.
there is some cytoplasmic clearing. Okay,
Yes,
so I was not very convinced about the fibrillary material which you were telling. Okay, probably you were looking at. So we are looking at the perithelium matrix pattern. So this is the large areas of necrosis you are finding. Okay, theme
Yes,
of
sir.
this today's topic. And so we have a literally like an undifferentiated. Did you find any melanin pigment or something?
Yes, sir. I have found some melanin pigments also on the slide.
We couldn't find melanin pigments. Okay, if you find it, found out, then it's well and good. So some 3 ICs were given for you, right? What are the ICs?
So the name of, sir, first one is the CK, which is found to be negative in the tumor cells.
Okay. Second one is
So second is the HMP45.
which is positive or negative?
So it seems to be positive, sir.
Okay, you have seen this right before?
Yes, sir.
Okay, so the
So
second,
the
the third one.
third one is the soft scan.
Sure.
So
Soft
it's
scan
also
is positive?
seems to be positive, sir. Sir, positive.
So what is your diagnosis now?
Sir, it can be, sir, melanoma also, sir.
Okay, melanoma also, no, she's still not convinced. Okay. So to summarize the histological features, we have a tumor with poorly differentiated morphology in sheets and peritheliomatosis pattern. So there is moderate pleomorphism, prominent nuclear and brisk mitosis. There are large areas of necrosis which are present. So there is no pigment deposition, gland formation, rosettes or fibrillary material. So the positive IHCs include HMB45, Soxton and Melanie. So this is just a summary of findings which you're doing, but actually practically we don't do this, right? We are writing like, based on the morphology, we write other IHCs also. The first important IHC what we need to do is a pan-cytokeratin, okay? P40, INSM1 and synaptophysin, okay? So what is INSM1? Any idea?
Insulinoma, like.
Okay. So INSM1 is insulinoma. So why is it done?
In neuroendocrine differentiation technique.
Okay. It is
Neuroendocrine.
the nuclear marker for neuroendocrine differentiation. So we also have synaptophysin. So all these markers are negative, and INA1 is retained. So this is a case of cynonasal mucosal melanomas. Okay. So this case, I just wanted to highlight the features which I illustrated before. This is called as the peritheliomatous pattern, which you thought of it's a pseudo, rosette. No, this is because of the survival pattern. Okay. So wherever there is blood supply, the cells will be attached to the with each other to the vascular core, and whenever there is loss of blood vascular supply, there will be necrosis, which leads to this pseudo. I shouldn't say that this is rosette. So this is a peritheliomatous pattern. So approach for cynonasal undifferentiated tumors should think of the possibilities of Ewing sarcoma, rhabdomyosarcoma, olfactory neuroblastomas, small cell carcinoma, lymphoma, and a melanoma. So these are the basic panel of IHC which we start with. Then we work up with further IHCs which if needed. So pan-cytokeratin for any carcinomas, small cell carcinoma and any deficient cynonasal carcinomas will be positive. So CD45 is for lymphomas, SOX10 is for the one is your melanoma, other one is a nerve sheath tumor, which is not actually a DD in this case. NKX2 is a specific marker for Ewing sarcoma. Okay.
Ewing sarcoma.
So desmin myogenin or myod1 we use in case of rhabdomyosarcoma.
Rhabdomyosarcoma. Okay,
good. So INSM1 it will be found in olfactory neuroblastoma, small cell carcinoma. So these are the differentials, and just for you to appreciate this tumor, about cynonasal melanomas, it's a rare disease. It represents around 4% of nasal and paranasal malignancies. The mean age is 65 to 70 years, so it's a disease of elderly. The presentation can be like a fresh ulcerated polypoidal mass. Pigmentation may or may not be seen. So it is derived from the neuroectodermal, from the cells which are there, which are the stem cells which are present in the derived from the neuroectoderm. And there are no comparable risk factors unlike cutaneous melanoma, where there is a risk of UV exposure. Okay, so this new cynonasal mucosal melanomas don't have any prior risk factors. So it is quite rare and aggressive disease, which is associated with frequent recurrence and distant metastasis. So it is delayed. Mostly the diagnosis is delayed because of the anatomical location. Okay, the presentation will be late and therefore it has poor prognosis. So unlike cutaneous melanomas where BRAF V600 is the most common mutation, in cynonasal mucosal melanomas the NRAS mutation is more common than that, and other mutations are KIT and CDKN2A loss which can be found. So I just wanted to highlight one more tumor which can show this sort of necrosis is the glioblastoma multiforme, or multiforme word has been removed. So glioblastoma, here you can see this is called as palisading necrosis. So here is the necrosis which is going here, and these are the palisades of viable cells which are present. So adjacent areas is showing vascular endovascular proliferation, and these are the prominence of blood vessels outside. So this is just another picture to depict that. So the cases are concluded. So may I go ahead with a brief discussion, or sir?
Yeah, thank you, Dr. Bala, for such an excellent case and very rare case. Yeah, I think all the students have been richly awarded for the time that they've spent here, and I hope everybody listened and learned.
Yes.
Anyone? Yeah. So basically, see the necrosis patterns, the apoptosis, and what are the conditions in which you see apoptosis, necrosis. So these are the specific conditions in which you see increased apoptosis, types of necrosis, whether it's a caseous necrosis or it's a palisading or it's a stellate necrosis. So these things you should remember. And thank you, Dr. Bala, for excellent slide seminar.
Excellent, thank you.
Yeah, thank you, Bala. So I hope the students were able to get a sense of how something as basic as necrosis, something as basic as apoptosis, which we learn in undergraduate classes, they actually are key diagnostic features in lots of diseases. We have shown only some 6 or 7 of them, but there is no disease or no condition where you're not going to get this, and you need to understand how even necrosis should form your differential diagnosis. If you look at something like cat scratch disease, who was the person who got cat scratch disease as a case presentation?
Me, sir.
Yeah, so if you want to summarize, what is your take home from the cat scratch slide that you saw?
Geographical necrosis will be present in cat scratch disease, sir.
Exactly.
Suppurative
Whenever you are
inflammation.
seeing a slide, if you find geographic necrosis, but Dr. Bala showed one more feature of that. What was the second feature which is not there in this case?
Suppurative inflammation.
Very good. So presence of neutrophils. So you can get neutrophils or you may not get neutrophils. Tuberculosis, you typically don't get neutrophils. Whereas in cat scratch and LGV, you get some neutrophil or neutrophilic debris. Lots of neutrophilic debris can be present. So presence and absence of neutrophils are a key feature. Can you tell 3 types of mycobacterial infections or 4 types that you might know?
Mycobacterium tuberculosis, Mycobacterium leprae.
Okay, so in leprosy, you may get tuberculoid or lepromatous, in which you get histiocytes full of bacilli. Tuberculosis, you get granulomatous inflammation. What about avium intracellulare?
Atypical mycobacteria like Kansas-C, Marinum.
So you nowadays can't just use the word atypical mycobacteria. You have to be more specific. So you uttered 2. One was Marinum. So what kind of lesion do you get in Marinum? You get cutaneous ulcers, and if you take sections from them, what you will see will be lots and lots of neutrophils.
Yes.
You get neutrophilic abscesses, and the organism will typically be found in large clusters. So it's not going to be single AFB which you are finding in between the inflammatory cells. You're going to find an area of necrosis within suppurative inflammation where lots and lots of aggregated atypical mycobacterium will be found. Whereas in avium intracellulare, what you will see? The word is there.
Intracellular.
You will find histiocytes. You are not going to find the usual necrosis, granulomas, because granulomas don't form in that. By definition, it occurs in immunocompromised, so not immune. And so you find the mycobacteria inside the cells. You will not find the classical necrosis in that condition. Who was the person who got case number 2?
Sir, it's me, sir. Naganandini.
And what was your diagnosis?
Kikuchi's Fujimoto's disease.
What is the key takeaway which you got from looking at this case? Have you seen a case of Kikuchi before?
No, sir, I have not seen.
Okay, so first time, that's good. So what is your key takeaway from seeing a slide of Kikuchi?
So there won't be any intact neutrophil in this
Brilliant.
condition.
You have hit the nail on the head. No neutrophil. So in the first case also, neutrophil is there or not there. Makes you change your diagnosis. Similarly, lymph node with necrosis, look at high power and see, is there or is there no neutrophil? Okay.
Yes.
Now, if neutrophil is there, what do you think of?
Any acute infections?
Acute, suppurative acute infection. Acute suppurative lymphadenitis is the most common probability. Whereas if you don't find neutrophils and you find this necrosis, what are the things? One, you will say Kikuchi. What are the other things you will think of?
Lymphomas.
Excellent. Lymphoma with necrosis. It will present in very similar looking. And apoptotic. So a lot of lymphomas may have a lot of apoptosis. So that's your DD. Okay. And what is the thing which you will hunt for to clinch your diagnosis of Kikuchi?
Eccentric histiocytes.
Brilliant. And do you get it anywhere else?
Yes.
You might get it elsewhere, but generally in this huge numbers, you get it only in Kikuchi. Practically, if you hunt for one or two, you'll find everywhere. But only in this condition, you'll find them everywhere. Who got case 3? What was your case?
Disease.
I couldn't hear you. Can you repeat that?
It's a graph.
Graft versus
Graph
host
versus
disease.
host disease.
What is your key takeaway from this case?
The apoptosis and the focal crypt dropout can be seen.
So there is a difference between cryptitis. So again, is it a neutrophil or is it an apoptosis? So everywhere. So neutrophils commonly undergo necrosis. They die very fast. And when they die, they leave few dots of nuclear material. And so your aim in almost every situation where you get necrosis, is it neutrophil? Is it apoptosis? Okay. So if you are thinking in terms of neutrophils, what is your thought process? Some kind of infection. Is there some infection going on because patient has a colitis, or it could be some other kind of colitis, cryptitis, cryptapsis, which you get in inflammatory bowel disease. Whereas if you get lots and lots of apoptosis, then you think in a completely different direction. Who got case 4?
Myself, Lakshmi. I got case number 4.
What was your case?
It's chronic hepatitis superimposed with
What's the key takeaway from that?
Sir, first I need to know the grading of the fibrosis because it's very important for treatment purpose.
So when you are analyzing any liver biopsy, almost everything related to necrosis and apoptosis you have to hunt for. Where do you look for the neutrophils?
Near the vessels, reported triad or portal.
You can get a biliary tract inflammation caused by neutrophils. You can get a piecemeal necrosis in which neutrophils are involved. You can get spotty necrosis in which neutrophils are involved. What else is at the center of spotty necrosis?
Hepatocytes associated.
Apoptotic body. So a hepatocyte which has undergone an apoptotic process. What delivers the apoptotic signal to that hepatocyte?
Phosphorylated
Perforin granzyme or a cytotoxic T cell, or some similar kind. So you are going to find in an area of spotty necrosis all three of the things we just discussed. You're going to find apoptotic cell, you're going to find T cells, and you're going to find necrosis. And if you do the marker, you will probably be able to find perforin expressing or granzyme expressing cells also. Where will you look? What else you saw? You saw ballooning degeneration or ballooning. What is that due to?
That is due to degeneration of the intermediate filaments.
No. So it's due to acute injury. Ballooning means that an injury is fresh and so the cells swell up.
Yes, sir.
Right? So ballooning indicates a new injury. The plasma cells indicate?
Antibody-mediated injury.
Or generally in liver, lots of plasma cells, you first think of autoimmune hepatitis because that's where you get a lot of it. So that's your diagnostic clue.
Yes, sir.
What about the fibrosis and what does it indicate?
Fibrosis will indicate how much tissue has been chronicity. It will indicate the chronicity of the disease.
Exactly. So there is a chronic process and there is an acute process. So the fibrosis is for the chronicity and the other features we just discussed are for the acute. Right. Now let's go to case 5. And who got that? Yeah. What was your case?
Extranodal enteral T-cell lymphoma.
And what's your key takeaway from that?
So a very aggressive tumor and with poor prognosis and angio invasion and extensive necrosis, like the pathological.
So not all tumors are going to look like tumor. Okay, so if you have a biopsy from the nose or palate or somewhere along the midline of the head and neck, and it shows a lot of necrosis, what are the 2 things which you should actively consider? One is this NK T cell lymphoma, lots and lots of necrosis. It will be there. What else you will consider? What your name, DD? You uttered it as one of your differentials. You thought of Wegener's
Wegener's
granulomatosis.
granulomatosis.
Wegener's is another thing you should consider. And the third thing you should consider is a fungal infection. Okay, so you got a nasal biopsy, you got lots of necrosis in the exam without thinking. Think of these three and then actively start ruling each of these out. How will you rule out Wegener's granulomatosis? Okay, so these are tough things to do. All three are difficult diagnosis. Fungus is the easiest. If you find the fungus, it's fungus. What is a clue? Finding of eosinophils, charcot-laden crystals, granulomas, giant cells. If you find a giant cell, look for the content of the giant cell. That is true in all histology. If you find a giant cell, what is the content of the giant cell? That will answer a lot of questions. Number two, if you have Wegener's granulomatosis, then you have to look for the vessels. Number three, if you have NK T cell lymphoma, again you have to look for the vessels. So what you find in the vessel is different in each of these. In one you have a vasculitis and in the other you have angiocentricity. So there is invasion and destruction of the vessel in both NK T cell lymphoma and Wegener's granulomatosis. Of course, in Wegener's granulomatosis, you may find some granulomatous inflammation. So the clue is you have to hunt for preserved tumor cells. Okay, almost anything in which lots and lots of necrosis is there, you obviously have been given that slide because something somewhere is preserved. Either a fungus is preserved or a tumor is preserved. And in NK T cell lymphoma, you will find, if you have been given a slide, some preserved cells like here, and then the IHC will clinch your diagnosis. Okay, who got the last case?
Sir, it's me.
Yeah, so what is your key takeaway?
Sir, the case was sinonasal melanoma, sir. It is a rare condition.
Interesting case. What is your key takeaway?
Sir, it is rare tumor presenting with extensive necrosis.
No,
Sir,
that should not be your rare. That should actually. So I was listening to you present.
Yes, sir.
You jumped to a conclusion of esthesioneuroblastoma, if not
Yes,
mistaken, right?
Yes, sir.
This is despite the fact that some IHC was given. Whenever you get it, in this there was no doubt that there is tumor.
Yes.
There was no doubt that there is necrosis. So when you have necrosis and you have tumor and you find a perivascular preservation of tissue, you have to carefully think, is it peritheliomatous or not? Some tumors have a tendency towards a lot of necrosis and peritheliomatous preservation, whereas others don't. Now, in this particular case, if you had made a diagnosis of melanoma, I would have been amazed because I would not have made. You have to start with your basic, which is carcinoma, sarcoma, lymphoma. Can you rule out carcinoma in this?
Yes, sir. The CK marker was a negative for the tumor.
Yes, but morphologically, which two carcinomas would have fitted? So melanoma is a carcinoma. And what is the other carcinoma which you have to consider with this kind of morphology?
Small cell carcinoma.
Sir, small cell.
Small cell carcinoma or a basaloid carcinoma. You have to consider or a sinonasal carcinoma. They can look like undifferentiated carcinoma, can look like this. So those are a number of diagnoses which fit in this area. Then sarcoma, can you rule out?
Sir,
So round cell sarcoma. So what would be your list of round cell sarcomas in this?
Sir, alveolar rhabdomyosarcoma, sir.
So alveolar, very good. So alveolar rhabdomyosarcoma. What else? Or any other kind of embryonal or other rhabdomyosarcoma.
Yes,
Then what else?
Sir, Ewing sarcoma, sir, it can.
It could be an Ewing sarcoma. It could be one of the other Ewings-like sarcomas or the Becker sarcoma or rearrangement sarcomas which occur in the pediatric age group. What else it could be in the sarcoma group? So you had one INI1 which was given. Which are the tumors in this region which could be INI1 deficient? Now, in this particular case, INI was not deficient, but had it been deficient, what all would fit in with this region. That is, nasal region, I think it was nasal or some such reason, or sphenoid process. So which are the SMARCB1 deficient tumors? Can you list them? Anybody else? Somebody else can just chip in.
SMARCB1 deficient tumor, sir. Then
What is that called in this nose, in the sinonasal region? So it could be an undifferentiated carcinoma. It could be, we just said that rhabdoid ATRT can be there, or rhabdoid tumor can be present in this region. So a number of other lesions which can fit in the sarcoma category or very close to it are also DDs. What about lymphoma? Can you rule out a lymphoma?
So lymphoma, sir, yes, sir. We can rule out some.
Difficult, no? It had a small round cell, but it had
Yes,
some cytoplasm. So if you had to think of a small round lymphoma, which lymphoma you would think?
B cell.
So it could have been some high-grade B cell or some such lymphoma could have been there. So the first panel of IHC you have to ask is cytokeratin, then vimentin and LCA. Or you can ask for Desmin because a little more. So Desmin CD99 for your round cell sarcomas because vimentin not very good. It's not spindle cell, and you have to do an LCA in such cases. You'll be surprised how many will turn out at the first panel to be lymphoma, or you will do the entire panel of lymphoma and then find that it's negative for everything, and then you go elsewhere. Okay. Another important takeaway from this is that which are the tumors in which you get palisading necrosis? Common, this type of peritheliomatosis or palisading necrosis. So alveolar soft part sarcoma, not alveolar, alveolar rhabdomyosarcoma you uttered. What does it show?
Sir, in alveolar rhabdomyosarcoma, we can get, sir, palisading necrosis also.
No, you generally get a fall. So it is alveolar because of fallout of tumor. So the tumor falls out in the center and leads to a false alveolar pattern. That is also preserved around the blood vessels. Okay. It is not exactly peritheliomatosis because peritheliomatosis you generally talk about long ribbons of preserved tissue in which alternating with long ribbons of necrotic tissue. Alveolar fall apart pattern is small rounded spaces where cells are falling out. Then palisading necrosis typically seen in GBM or glioblastoma is again preservation around the vessels and necrosis in the areas away from the vessels. Where else you will get that?
Sir,
you can get it in virtually any tumor. Almost all tumors will end up showing this if there is some ischemia to that tissue. What is Garland pattern of necrosis? So typically you get that in lung carcinoma or sometimes in colonic carcinoma. In that there is long ribbons of necrotic tissue and long ribbons preserved. So it looks like areas of Garland. Preserved, not preserved. Preserved, not preserved. Typically seen in carcinomas, lung carcinomas. Okay, so the patterns of necrosis, patterns of apoptosis are very important in how you think of your DDs and arrive at a diagnosis. Okay? Sure. Thank you. Is there anything further to add, Bala and ma'am?
No, sir. I think you very nicely
Thank you,
explained and very detailed. So I think I have nothing more to add, sir. Thank you, sir.
So there is a question, Dr. Bala. Is necrotizing granuloma same as suppurative granuloma?
No. So the way suppurative means it is neutrophils. Okay. Necrotizing granulomas means generally when we say there is this eosinophilic granular necrosis, that you find that debris, nuclear debris which is present inside the granulomas. When we say suppurative granulomas, they mean they are neutrophil rich granulomas. So both are different.
Yeah.
And there's another question. In Kikuchi, why does the proliferative stage come first and the necrotizing stage comes second? Why can't it be a reverse phenomenon?
So the initial trigger, the pathogenesis is just that the once some sort of an autoimmune process is an exaggerated autoimmune process. So the initial step for anything is it has to proliferate first, then the execution starts. So once the perforin that pathway is activated or death ligand pathway is activated, then it undergoes apoptosis. So the natural course of the disease is that once there is an environmental trigger or a viral infection or any autoimmune response, so to counter that, there is proliferation of cells. That is how the immunity works. Then, because of the end product, whichever is the secretion, that it per se it undergoes necrosis, and then it undergoes apoptosis, and finally there is resolution. So that is a natural course of Kikuchi disease.
So I have a doubt that in the proliferative stage, what could be the clue to identify? Can it be missed?
Yeah, it can be missed. In fact, there was one case which we recently saw. I thought of PTCL. So then there were some clues of some apoptotic debris. Another important thing is you need to take clinical input here. Okay. So if the patient has a short history, single lymph node, young female with this type of presentation, if there are multiple lymph nodes, splenomegaly and hepatomegaly and stuff like that. Second thing is if the IHC profile is not fitting. Okay. If you have to see that mostly your Kikuchi's disease proliferative phase, usually CD8 positive cells, CD8 positivity. And when you're going to work up, because you're not going to go in any other particular lymphomas, you will be sticking to the T cell lymphomas. In the T cell lymphoma, you are finding that there is increased CD8 and negative for any cytotoxic markers. EBER is negative. And you're finding some apoptotic debris with this type of histiocytes and proliferation that has to clinch. But yes, mistakes have happened, and you have to be cautious for that.
If I could just add to this, Kikuchi is very frequently misdiagnosed. Kikuchi usually presents as patient gets fever and some cervical lymph nodes come. Typically somebody from northeast or hills or something like that. And in the first week, they just rest. They take some antibiotics. They don't worry about it. Then the fever continues. So actually the patient is in fact having a viral infection and is responding abnormally to it. But you don't want to do a biopsy of that lymph node because he's just had fever for a week or so. Now, if the fever goes on for 3 weeks, that's when people start getting worried. They start investigating them for pyrexia of unknown origin.
Yes.
Then, if you have PUO and you have a lymph node, what do? You think, is it tuberculosis? Is it malignancy?
Yes.
These are the common reasons for a lymphadenopathy with PUO. After you rule out typhoid and other things. So then you take out the lymph node thinking, okay, maybe there is a malignancy because patients have lots of lymph nodes. You take it out saying, is it malignancy? And if you find it in the proliferative stage, you will misdiagnose. I have had both situations happen. We have seen ALCL being misdiagnosed as Kikuchi. And we have seen T cell lymphomas being misdiagnosed as Kikuchi and vice versa. You think that it's, a lymphoma and you work it up and all the markers you do, it turns out to be Kikuchi. So you have to be careful. Both of these situations, you do get necrosis, you do get apoptosis, you do get a lot of debris and you can easily go wrong. Okay. Yeah. Yes, Bala, any other questions?
No.
Loss of T markers, T antigens, when we say for PTCL, you do multiple T cell markers and find the loss. So that might, help you in that. Finally, clonality studies, that is the only way to prove it. If it is monoclonal, then it will be PTCL. If it will be polyclonal, then that's the ultimate endpoint for you.
Yeah, so just compliments for you. It was a superb session. Excellent, wonderful. Thank you, Venkateshan sir, and thank you, Balamuthil sir. Thank you, Jaswinder ma'am. So with this, I think we have reached the end of the session.
Thank you. Thank you so much, everybody.
Thank you.
Thank you, sir.
Thank you.
Thank you.
Thank you for attending, to all the attendees. See you on Thursday.
me.